Hello everyone. In today's episode, we'll be talking about how to assess whether there is cephalopelvic disproportion or whether the head has engaged or not. So, when the head is at the level of the brim of the pelvis and you do a per-abdominal examination, you can feel whether the head has engaged or not. How it is done? This is by the Crichton's method. In Crichton's method, we feel for the fetal head. So, if the fetal head is not engaged, then it will be 5/5 palpable. That is, all the 5 fingers will palpate the fetal head. When the fetal head starts going inside the pelvis slowly, you will have 4/5 palpable, 3/5 palpable, 2/5 and 1/5 palpable. When it is 2/5 or less palpable, then we say that the head has engaged. That is, the biparietal diameter has crossed the pelvic inlet and the presenting part has reached up to the ischial spines. So, in that case, it will be less than 2/5 palpable and head has been engaged. Now, if we go with the abdominopelvic method, then we have modified Muller-Monro curve procedure. In modified Muller-Monro curve method, with the help of your left hand, you try to hold the fetal head and try to engage it into the pelvis. On the other hand, with your right hand, you insert the index finger and middle finger of your right hand into the vagina, and the thumb of the right hand will be above the pubic symphysis. With your 2 fingers, you try to feel for the ischial spines. The vaginal fingers will feel for the ischial spines and see whether the head has come to the ischial spine, that is the 0 station. Now, with your left hand, you will try to push the head into the pelvis and try to push it up to the level of the ischial spines. So, with your 2 fingers, you try to feel whether it has gone up to the ischial spines. Now, there can be 3 types of interpretation. Number 1, if you can easily push the head up to the ischial spines and there is no overlapping of parietal bones over the pubic symphysis, which you feel with your thumb, then there is no cephalopelvic disproportion and the head will, the pelvis is adequate and can easily deliver. If you can push the head only a little bit but not up to the ischial spines and there is slight overlapping of the parietal bones over the pubic symphysis, then there is slight cephalopelvic disproportion. And if you are not able to push it at all, but there is overlapping of the parietal bones over the pubic symphysis, then there is severe cephalopelvic disproportion. So, and apart from that, there is some historical importance that you can have X-ray pelvimetry. If you anytime advise somebody for X-ray pelvimetry, then a lateral film of the pelvis is taken in erect position. So, female stands erect and you take a lateral film. In that, what all things you can observe in that X-ray? One is all the anteroposterior diameters can be seen. The sacrosciatic notch, whether it is wide apart or not, it can be seen. Whether the sacral curve is properly concave or not, so the curvature can be seen. Then the ischial spine, whether it is prominent or not, can also be seen. And whether the fetal head has reached up to the ischial spines, that is at 0 station, whether it has reached, all these things can be appreciated in the X-ray. Moreover, ultrasound pelvimetry and all these are historical aspects. These are generally not done. So now what we practically do is the clinical pelvimetry, which is done at the onset of labor, because when the labor starts, the relaxin hormone which is released into the blood helps in relaxation of the pelvis and the soft tissues. So this is the time when you can go for clinical pelvimetry and assess the pelvis. This is very much appropriate for primigravida because in multipara, if there has been previous history of normal vaginal delivery, then anyhow pelvis is adequate. For more informative videos, remain subscribed to our channel Medi Mantra.